All right, I'm here with Michael Tam, who presented some research today at the CPHC Annual Forum into a project called ED to GP. So Michael, could you tell us a little bit about the research series?
Yeah, so it's a series of focused on what happened to older people after going to the emergency department and going home. And the particular question we wanted to know is what proportion of people followed up with their GP within a reasonable time frame. And we defined that as within 7 days after leaving the emergency department. And we wanted to know not just the proportion of people, but whether or not there were any associations, any sort of factors that make people less likely to follow up. Now in that study we found that approximately 80% of people did follow up within a week, but some interesting variations came up which we weren't entirely sure we were not entirely sure whether they were real and what they meant. One of the really sort of interesting findings was that there was a big difference between older men and older women, where almost all older men had followed up by a week. Only around 60%, two-thirds of older women had followed up, and that naively seemed like that might have been the other way around. We know that women tend to access the GP more than men. So the second project we really wanted to explore that finding, and so we recruited older women, so women over the age of 65, presenting to an ED in southwestern Sydney, and in that one we rather than just measuring proportions of whether they had done something or not, we sort of asked them questions on what led to their follow-up behaviour. So we asked their intentions while they were still in the emergency department, and then phoned them between 1 to 2 weeks after discharge to see what they had actually done and their thoughts and their understandings on what led to that outcome, or what their thoughts were about follow-up. And that really gave us some insights on that finding of the lower rate of follow-up, particularly the sort of status of older women in their care duties. Most of the older women were not drivers, so they were reliant on family, and there was this notion that they were inconveniencing their family members to go to the doctor. One of the other findings was that is, I suppose, more positive and potentially leads to a way of empowering women and changing practice, was identifying the importance of some of the messaging that occurred in the emergency department at the point of discharge. So, for instance, if the ED sort of framed the follow-up with the GP as important for the ongoing care rather than as a administrative task or a notional thing that they would say, that was seen as something that would drive some follow-up behaviour. And potentially, if that was noted with family members, these are the potential family members who would need to take the older person to see the GP. In the first two studies, one of the things we noted was that the majority of people spoke language other than English at home. The most common language spoken in the Fairfield region is Arabic. And we know from existing research that when the doctor and the patient don't speak a mutual language, there are quite a lot of risks for miscommunication, potentially dangerous miscommunication. If I came in with chest pain and I thought you told me that I had reflux, but I actually have a heart attack, that's not good. So in the study that's actually running now, we're looking at the communication between Arabic-speaking patients and doctors in the emergency department, and seeing the level of concordance in communication, and again what factors might lead to problems. For instance, language proficiency in English, in Arabic, any other languages, and any other factors leading to that. Now that project is still underway. Data collection has finished, but we haven't analysed the data yet, but we're already seeing some fairly interesting dot points, I suppose. For instance, of the 172 participant pairs that we have recruited, so that's the doctor and the patient, we would have probably expected that at least some people would have used a professional interpreter as part of the consultation. That's seen as the gold standard, while it looks like the actual rate observed is very, very little, potentially none in that cohort of patients. And that's not to say that the doctors are doing the wrong thing or anything like that, but it really highlights what happening on the ground in terms of the care that can be provided in real life practice now may not be quite meeting the expectations of the community and what we think is actually good practice.
And your colleague presented some interesting stuff about relationships with between ED doctors and GPs, and it was a qualitative study.
Yes.
Could you touch a little bit on those findings?
Yeah, so having worked both in general practice and in emergencies, there is a little bit of antagonism, a bit of tribalism between the two groups. EDs might get correspondence from doctors, from community doctors, from GPs that they think might be a little bit hopeless. And as a GP, sometimes I might have the same thoughts receiving discharge communication from the emergency department. Even though at a theoretical level we kind of know that people are trying to do their best within their respective health sector. And what we really wanted to do in that study, so what my colleague Andrew Knight wanted to do, was really to start to bring the two groups together to understand their perspectives on how to better work together, how to better integrate care between general practice and emergency departments. And one of the key insights that really comes out, and I suppose we sort of know it, but it's really good to have this affirmed, is just the importance of relationships, trustworthy relationships that are respectful between the two parties. And if we understand each other, we're just much more likely to have respect, to sort of understand the challenges and work together rather than retreating to our own tribes, I suppose. I think that project the analysis is mostly done, and I'm not terribly au fait with all the intricate findings, but they did. But it's really great getting the two groups of clinicians together. They sort of identified potential priorities that could be actioned on as initial quality improvement to improve the quality of care, improve the integration of care between general practice and emergency departments, and I believe that's going to go ahead fairly soon.
Excellent, thank you, and apologies about the background noise.